All right, I'd like to welcome everybody to this Facebook Live session. My name is Dr. Tim Tollestrup. I'm a pain-focused peripheral nerve surgeon. Um, what we've done here is just curated a bunch of questions. We had many more questions submitted than we could potentially answer in a reasonable amount of time. So what we've done is sort of gone through the questions and curated them so that we pick questions that were representative of problems that came up again and again. So what I'm going to do is just start reading these questions. They were submitted by various people, and we'll just go through and I'll read the question first and then talk about the solution or answer the patient's specific inquiry. So the first question says this is from Trista, a person named Trista, and she says, "Hello, Dr. Tollestrup. You did surgery on my nephew a couple of years ago, Brennan. This was a patient that I operated on, teenage young man who had an inguinal hernia repair and developed chronic groin pain." And Trista says, "I know and believe in the work that you do. I had gallbladder surgery this spring, March 16th to be exact. I have had pain in my rib cage ever since. I recently went and had an ultrasound done and nothing looked abnormal. I am wondering if you believe it could be nerve damage. I am a 37-year-old woman, 5'6", 165 pounds, in very healthy condition." So this is a good example of a situation where intercostal nerves have been injured from a laparoscopic surgery. When they do laparoscopic surgery to remove your gallbladder or your appendix or do anything else that they might need to do laparoscopically, what they do is they inflate the abdominal cavity with CO2 gas, and then they just push essentially little knives through the abdominal wall so that they can insert ports that they can then pass instruments and the camera through to complete the surgery they're doing. The location where these ports are inserted is simply where the surgeon wants it to be so that they can effectively complete the operation inside the abdomen. There's really no thought given to, any nerves that might be passing through that anterior abdominal wall area that could be injured. And to be fair, there's no real way to exactly see where the nerves are or whatever. So it's just kind of a hit and miss thing. Most people will have laparoscopic surgery and not have a problem, but occasionally some patients will have one of these anterior intercostal nerves damaged as the trocar goes through the abdominal wall. And I would say that's probably clearly the case in this with this patient. And so once one of these nerves has been damaged, what the patient's going to experience is pain in the abdominal area. It may radiate towards the midline in the front, and it could also radiate around the side and even all the way back to the spine, because pain will often follow the course of the intercostal nerve that's been damaged. Sometimes these trocars don't go just straight through the abdominal wall, but go through the abdominal wall at an angle, in which case it's possible to injure more than one of these nerves. So they could get one or even two nerves, depending on the angle that the trocar is inserted through the abdominal wall. But this is the type of a problem that can definitely be fixed. The key here is to identify the appropriate nerves with diagnostic blocks. That confirms that the problem is actually peripheral nerve, and then it also helps to know exactly what level and where to make the incision so that you get the right nerve. You're not taking out a nerve that's not the problem. So that's definitely a problem that can be fixed. The next question is from a patient named Elise. And Elise says, "Hi there, I'm looking for a second opinion. I recently just had Meralgia Paresthetica surgery on both legs. I have severe thigh pain in both legs. The condition is due to diabetes type 2. I am 31 years old and I see a UCSF neurologist. I am still having the same severe pain even after both surgeries that has happened. I was wondering if you take medical insurance or what or what you can give me my next medical advice. I just got a referral with our Stanford Hospital Pain Management. I have been on opiates for about 4 years now, but now it is not really helping to suppress my pain. I am not able to do a lot of daily activities. It completely consumes my life. So this sounds like somebody who has had a decompression surgery on both legs. Meralgia paresthetica is a condition that involves compression of the lateral femoral cutaneous nerve. The lateral femoral cutaneous nerve is a big nerve that innervates sort of the front and outside part of the thigh. If you were to draw a line right from the groin down to the kneecap in the middle of your thigh, that part of the front of the thigh to the outside and then wrapping around to the side of the thigh is typically the territory of the lateral femoral cutaneous nerve. For most people that say they've had Meralgia paresthetica surgery, what this would mean is that somebody has tried to decompress or relieve the pressure on these nerves. It sounds like in this case that has not relieved her pain. So assuming that the diagnosis is correct, number one, which should have been made with a diagnostic block. So you block these nerves and make sure the pain goes away for a couple hours to prove that it's the lateral femoral cutaneous nerve that is the problem. And then there's two options. You can either try and decompress the nerve or you can disconnect the nerve. And my guess is that this person had a decompression where they left the nerve intact but just tried to open the space up around the nerve. This lady also has type 2 diabetes. So anybody with diabetes or hypothyroidism are at increased risk for developing nerve compressions generally in many places in the body, and certainly the lateral femoral cutaneous nerve is a common nerve to become compressed in these patients. It sounds now like that the surgeon that did the surgery doesn't really have any other answers for her. And so she's just been given a referral to pain management. The real solution for this patient now would be to go back and disconnect these nerves. I find that in my practice, when I have somebody with Meralgia paresthetica, my preferred approach to this problem is actually to disconnect the nerve rather than to decompress it. Disconnecting the nerve is typically 100% effective. You do have to deal with some phantom pain, which is temporary. That'll go away, and then there's just some numbness in that area of the thigh, which is very well tolerated long term. With a decompression procedure, there's nothing wrong per se, but you do run the risk of the pain not being resolved or coming back because the nerve scars in badly. The other issue with the lateral femoral cutaneous nerve is that it's a very complex nerve from an anatomic perspective. There's lots of variation. There can be one nerve or there can be two or three nerves that are sort of coming out of the pelvis and innervating this area. And so if you did a surgery to decompress the nerve but didn't identify these other nerves, you could injure one of these nerves. I mean, there's a lot of explanations as to why this patient may still be having pain. So what she needs now, a pain management physician is never going to be able to solve this lady's problem. Also, oral pain medications and things like that are not going to be able to give her any kind of significant relief. The other part of her question here is she was wondering if I take medical insurance, and the only medical insurance I accept is TRICARE in my region. The U.S. government, in their infinite wisdom, does not allow you to accept TRICARE across the nation. So I do that just so I can take care of veterans that are in my area that need this kind of nerve surgery. But otherwise, I do not take medical insurance. So that answers her question. But I would encourage this person to find someone who has a lot of experience with Meralgia paresthetica and operating on the lateral femoral cutaneous nerve. She should probably have the nerve reblocked to confirm that that's the source of the nerve, and then what she needs is to have the nerve disconnected, most likely. All right, moving on. The next question. This was submitted by a gentleman named Philip, and he says, Both ankles feel as if a tight rubber band are around them. I can barely walk. Am I a candidate for nerve decompression surgery? So what I would say to Philip is that sensation that he describes of a tight rubber band being around his ankles is certainly very consistent with the type of symptoms that people who are suffering peripheral nerve problems describe. A feeling of tight pressure or squeezing, those type of symptoms. That's sort of one way that peripheral nerve um, symptoms can manifest. I wouldn't know if he's a candidate for nerve decompression surgery without being able to examine him and see if he shows evidence of nerve compression. Um, so, while the symptoms he describes certainly sounds consistent with a peripheral nerve problem, it always takes a physical examination by somebody who knows how to perform a peripheral nerve evaluation to ultimately determine whether somebody is a good candidate for nerve decompression surgery or not. Okay, now, question number 4. Is it possible, this was submitted by a woman named Polly, and she asks, is it possible for neurectomy of the lateral femoral cutaneous nerve for Meralgia Paresthetica to be unsuccessful? If so, how, and what would be the solution? So what she's asking is if the nerve has been cut, but the symptoms are not better or maybe worse or different, what else can you do? So first of all, when you cut the lateral femoral cutaneous nerve, you really need to know what you're doing and where to cut the nerve. I've seen patients who have had the nerve cut but have not had the nerve cut far enough into the pelvis or deep enough into the pelvis, and then the nerve can scar up to sort of the pelvic rim just inside the inguinal ligament, and that can lead to a situation where they have a painful neuroma develop that is subject to twisting and blunt forces from something rubbing up against the abdominal wall in that location. So the first thing you have to make sure when somebody's had a neurectomy but it's sort of failed is that, was the original surgery done correctly? Was the nerve cut and placed deep enough in the pelvis that it's not going to be a problem? The other common reason for a neurectomy of the lateral femoral cutaneous nerve for Meralgia Paresthetica to fail is that there's complex or unrecognized anatomy involving the lateral femoral cutaneous nerve. So the surgeon may have gone in, cut one nerve, but failed to address the second or even third nerve that's present, and so the patient can still have significant symptoms. So that's why it's so critical when somebody has a peripheral nerve problem, whether it's Meralgia Paresthetica or something else, that they seek out a surgeon who really knows what they're doing. Peripheral nerve surgery is not something that you should dabble in as a plastic surgeon or an orthopedic surgeon, because you're not going to get good, consistent results. And maybe for an easy, straightforward case, it's going to work. But if you get somebody who has unusual anatomy or maybe a problem that's not Meralgia Paresthetica, but the surgeon doesn't recognize it because they don't have the experience, that's going to be a problem. Next question, it's submitted by an anonymous person, but they ask, can a patient who has had a neurectomy ever be stuck with phantom pain forever? So typically when you disconnect a nerve that's a sensory nerve, so it innervates an area of skin, the larger the area of skin that nerve innervates, the more likely the patient is going to have some form of phantom pain. Now, if the initial surgery is done correctly and the nerve is treated appropriately, in my experience, phantom pain goes away 100% of the time. In patients who have a nerve cut and, like 6 months after the fact, they're still complaining of quote unquote phantom pain, what's typically happening is that there's some problem that's not been recognized, whether it's unusual anatomy, so there could be a second nerve involved. The initial nerve that was cut was not done in the correct way at the correct level, or there could be a lesion higher up the chain, meaning maybe they cut the nerve, but upstream from that area, the nerve is compressed, for example, and that was never recognized. So They may still be having the symptoms that they're thinking are phantom pain, but it's really due to some nerve that's still intact or a nerve that's compressed higher up the chain. When just phantom pain itself, typically if the nerve that's been cut has been treated appropriately, then that will go away 100% of the time. I've never had a patient in my experience where phantom pain has not gone away. If it doesn't go away after, if you're still dealing with that 3 or 4 months down the road and it's not showing a clear trend towards resolution, then you have to look for another problem. All right, next question. This was submitted by someone named Yoli. And this person says, in your experience, can the piriformis muscle cause or contribute to tendon ligament snapping in the hip? In addition to Piriformis syndrome, I have gait issues in the right leg and scoliosis. And I've previously had a fractured iliac crest from a traumatic injury. I'm not exactly sure what causes tendon snapping. What I can say is that in a certain percentage of patients with Piriformis syndrome, some kind of snapping or clicking type of sensation goes along with that problem. I can't really say how it contributes to that because most people with Piriformis syndrome don't describe those kind of symptoms, but clearly some do. So I'm not really sure. I mean, I'm not even sure if it's really a tendon or ligament snapping, but the patient will clearly describe that they're experiencing that kind of a sensation, a popping, a snapping, something along those lines. Occasionally it's audible to another person, but sometimes it's not. It's something that only the patient themselves can sort of experience. So, it's a little bit hard to know exactly what's going on there. I do know that in somebody who's got true piriformis syndrome and complains of this, typically when you take the piriformis muscle out, that symptom goes away. So clearly it can be the piriformis muscle that is somehow causing that snapping or popping sensation. Next question, submitted by a person named Dom, and this is actually somebody that I have seen in clinic, have not operated, but his question is, Dr. T, you diagnosed me with bilateral piriformis syndrome. My MRI was cleared, meaning the MRI of his back. But now I'm being told that I have foraminal narrowing causing my sciatic nerve pain from my spine by a different surgeon. Conflicting and confusion. I'm at the tipping point on deciding. What do you suggest? Tingling sciatic nerve pain down both legs, behind the legs, into the feet with buttock pain. I can't stand more than 20 minutes and can't sit more than 30 minutes without pain. Thank you. So I went back and looked at this patient's chart and reviewed the MRI of the lumbar spine. Now, this patient does have a history of discectomy, laminectomy in the low back, but his current MRI of the lumbar spine does not show any areas that would be significant in terms of an explanation. Like there's no evidence of spinal stenosis and no evidence of anything compressing any of the nerve roots throughout the lumbosacral region. I think this is a good opportunity to talk about spine surgeons and how uniformly ignorant they are about peripheral nerves. So pretty much anyone who has any kind of degenerative changes or postoperative changes of the lumbar spine who is experiencing these kind of symptoms, sciatica symptoms, who goes in and has an evaluation by a spine surgeon, they're going to be very highly likely that they're going to be told that the problem is coming from their back. For this person, what I would recommend is maybe seeking out a second and even third spine surgeon to look at the MRI images and look them over carefully. Diagnostic blocks or injections into the piriformis muscle can help. An MR neurography of the pelvis can help to differentiate this from something coming from the spine. But an MRI of the spine is pretty darn good at telling you whether or not the problem is spine related or not spine related. And in this case, the patient had an MRI that really didn't show any evidence of that. So You know, clearly this person is a little bit confused now because they're having one doctor telling them it's piriformis syndrome, that would be me, or likely piriformis syndrome, and another doctor saying, well, it's coming from your spine, you need back surgery. So in that case, what I would do is seek out a couple more opinions from other spine surgeons who are reputable in the community, and see if they agree with the recommendation of the first spine surgeon or not. Um, it would also be a good idea to have the diagnostic injections in the piriformis muscle, because if you get a diagnostic injection in the piriformis muscle and it takes away that sciatica pain, then you can be pretty sure that it's not coming from the spine and that it is actually piriformis syndrome. Next question. This was submitted by a patient named Giselle, or not a patient necessarily, but a person named Giselle. And she says, I recently had a peroneal nerve release revision surgery. So, what that means is she had her common peroneal nerve operated on, released once, and then she had to have it done again because the initial procedure was unsuccessful by an orthopedic surgeon. So, the second surgeon that operated on her gave her these findings. She says, my nerve was encased by severe scar tissue, which had to be removed. Deep underneath the scar tissue, my surgeon, the second surgeon, saw that very briefly over a 1 to 2 millimeter stretch, my common peroneal nerve went from looking like a normal single nerve to a, quote, split nerve with two main fascicular bundles back to a normal looking nerve. He did not think it appeared to be a neuroma because the fascicles looked healthy and I do have full motor control over my leg. However, he has never come across this anatomy before and believes that my nerve was inappropriately dissected by my previous surgeon. When I expressed concern over the split, he told me that the nerves can be dissected without being injured, but I am still confused about this. Does dissecting within a nerve entail cutting the epineurium? Is it possible for the epineurium to repair over time, or does the dissection render my peroneal nerve more vulnerable to future injury? Quote, or in parentheses, she says, I am assuming that it does. Thank you for your time. I just wanted to reach out to an expert because I cannot find much information on this through internet searches and am not able to speak with my surgeon for a few more weeks. So, what I would say generally about this is the patient seems to be doing well with no current symptoms, no weakness, no pain or loss of sensation. And so I wouldn't worry about this too much. Any surgery that you have to do around a peripheral nerve is going to cause some scarring around the peripheral nerve. Technically, that would, predispose the nerve to having an increased chance of being injured if there was some kind of traumatic injury to the leg, because the nerve is not going to be able to glide quite as well as a normal nerve under normal circumstances. But again, it's not something to lose sleep over or worry about excessively. This description that her surgeon gave her of the nerve looking like it split apart over a 1 to 2 millimeter stretch, that's a very, very small segment. I'm not exactly sure what this person saw. I don't know this other surgeon, but a lot of times these types of surgeries are done by surgeons who don't have a lot of experience, meaning, they may do 1 or 2 or 3 of these types of cases in a year. And it's tricky. I mean, it's a little bit hard to know exactly what he saw without either reading the operative note or seeing it yourself. I will say that this patient's concern about having the epineurium, the outer lining of the nerve cut, is not a big deal. That's something that is frequently done to decompress nerves, or when in just operating it, especially if a nerve has been scarred. Sometimes you have to go inside the epineurium to release the nerve and pull it away because the outer layer of the nerve is very stuck and scarred down. So as long as the nerve fascicles themselves are not injured or damaged, then the nerve should work fine. And I don't think this is something that she needs to really worry about excessively long term. Next question, submitted by someone named John. And John says, can you help with nerve damage from post-infectious myelitis autoimmune response. My 77-year-old father-in-law is in very poor shape since his episode earlier this year. He is an old hippie but a great guy who was in perfect health until now. He can barely walk and needs a walker / wheelchair to get around. So the word myelitis implies inflammation of muscle tissue. So technically that's not a nerve issue, it's a muscle issue, and therefore on paper would not be something that I could help this gentleman with, unfortunately. I will just say that lots of things that are peripheral nerve get misdiagnosed as something else. So ultimately, in order to know whether or not this person does have peripheral nerve issues that could be helped, he would have to be evaluated by somebody who knows how to do that kind of evaluation and examine him. And that would pretty much clear up whether or not there was a peripheral nerve issue going on or whether indeed it was a muscle inflammatory issue. Next question submitted by someone named Vanessa. Sort of a two-part question. She says, "Hi there, I saw on Instagram that Dr. T is taking questions. I have two about his Piriformis Syndrome surgery." So the first part of the question is, how does the body perform without the piriformis muscle? Are you able to live a full life without it? Anything you can't do once it is gone? That's a good question, and one that most patients who have piriformis muscle and who are contemplating surgery ask. So the answer is basically the only thing you can't do without your piriformis muscle is contract your piriformis muscle because it's gone. Other than that, the piriformis muscle is sort of a spare part like your appendix. It does have a function, but without it, you can do whatever you want to and you'll never know it's gone. I've had patients who've had their piriformis syndrome removed who go back to golfing, to playing pickup basketball, to downhill skiing, to hiking. Just a few weeks ago, I had a patient who'd had her piriformis muscle removed for Piriformis Syndrome. She was an avid marathoner, and she had texted me and was very excited because she had just qualified for the Boston Marathon and actually had run her fastest time ever in doing so. So in her case, it seems like she got faster without her piriformis muscle. I don't know if there's a direct correlation there, but the point is that there's really nothing that you'll be restricted from doing after removal of the piriformis muscle. And one other thing that patients who have significant piriformis syndrome don't think about as much is, what are you doing right now with the problem? Typically, they're very limited in what they can do, and so it's kind of a moot point about what you could do after because you're not doing anything now anyway. But just to waylay those concerns, without the piriformis muscle, you can do absolutely everything. The next part of our question, it says, I have all the symptoms of piriformis syndrome and sciatica, but also have pain in my upper body. The pain / tingling starts in my left glute, and while it does travel down my leg, it also goes up my spine to my neck and down my arm. Is this something that Dr. T has heard of? So, most commonly, patients with piriformis syndrome will have some form of buttock pain. Pretty frequently, they'll have pain that radiates up into the lower back, so the lumbar area, and then pain that travels down the back of their leg, and it can go all the way to the foot, or can hop around, or go halfway down the leg, etc. There's all different kinds of presentations with that. I have had several patients with piriformis syndrome where instead of just radiating up into the low back, the pain can radiate all the way up into the cervical spine and even into the base of the skull. I've had a few patients like that. I have not had a patient where the pain is also radiated into the arm. This would be a situation where it'd be useful to have a diagnostic injection into the piriformis muscle to see what that does. Now, there's no single test you can do for piriformis syndrome, if negative, that proves you don't have it. But if you get the piriformis injection and it relieves that pain and the pain in the arm, then you know pretty definitively that it's just a referral of pain into those areas from the compression of the sciatic nerve. I will say with symptoms of pain radiating down through the arm, that it's also pretty likely that she could have a second problem in conjunction with the piriformis syndrome. So for the symptoms of pain and whatnot radiating into the arm, it would be important to evaluate the cervical spine, make sure that there's not a herniated disc in the neck that's causing those kind of symptoms. And then also, it would be important to evaluate the patient for a condition called thoracic outlet syndrome, and more specifically, neurogenic thoracic outlet syndrome, because that could also be causing those kind of symptoms. So, um, while the radiation of the symptoms up the spine as far as into the neck and even the base of the skull is something I have seen before on occasion with patients who have piriformis syndrome, I have not personally seen a patient where they're also getting symptoms radiating down into the arm. And so that makes me just think about the need to evaluate for a second problem. Next question, submitted by a person named Polly. And Polly says, I'm 4 weeks post-op after LFCN surgery, so LFCN neurectomy. So again, this is a patient who has had the lateral femoral cutaneous nerve cut to try and resolve the condition called Meralgia Paresthetica, which is compression of that nerve. She states, I had sunburn sensations and zingers for 3 weeks. These have now gone, but I'm still getting a painful pinching nerve pain in the newly numb area. Is this also phantom pain or something I should be worried about? So Polly has sort of perfectly described the two most common sensations that comprise phantom pain. This sort of deafferentation pain that you get after cutting a nerve that innervates an area of skin. So the two sensations are the skin itself will become sort of hypersensitive and very often feel like it's burning, like a sunburn or a bad sunburn sensation. And the other sensation that you get is these intermittent, sort of random, out of the blue electrical shocks or zingers that just zip down into the leg where the nerve used to go. She is now, I guess, 4 weeks after having had the lateral femoral cutaneous nerve disconnected. She said that the sunburn sensation and the zingers seem to be gone, but she's still getting a painful pinching nerve pain in the newly numb area. So I'm assuming that she's talking about that part of the thigh, the front and outside part of the thigh that nerve typically innervates. What I would say is that at 4 weeks post-op, this is most likely still phantom pain. The larger the nerve that's disconnected, the more likely the patient is to experience phantom pain, and the more likely that phantom pain is going to be a little more significant and last longer before it goes away. And so, in my experience, when disconnecting the lateral femoral cutaneous nerve, it's not uncommon for patients to have symptoms as long out as 6-8 weeks or even longer on occasion. And some patients I've seen are still dealing with the tail end of phantom pain symptoms as long as 3 to 4 or even 5 months in the most extreme cases. I would say that if you're and the other thing that's important about that is that if it is truly phantom pain, then it will go away. And so what you typically see in even the most severe cases is that it typically peaks around the 6 to 8 week post-op mark, and then you see a definite trend towards getting better. If you're dealing with quote unquote phantom pain and it's been 3 or 4 months and there's been no trend towards improvement, then you have to start worrying that there's something else that wasn't recognized, or that the surgery wasn't performed correctly, or that there was a second nerve that wasn't addressed, etc. So it's really important to think carefully about what you're experiencing if you're the patient, because that information can be invaluable. To a surgeon who might take care of you down the road. I've had patients in the past who have Meralgia Paresthetica where you disconnect the main lateral femoral cutaneous nerve, and then they come back and say, oh, I still have the pain, it's not better. But on closer questioning, what you find is that part of the thigh is better and part of the thigh is not better. And typically what you have to look for is a secondary nerve that's innervating, maybe the lower half of the thigh or the medial half instead of the lateral half. And you have to figure that out and then address that secondary nerve or unusual nerve anatomy. Next question, submitted by someone named Joanne, and her question is pretty short and sweet. It just says, have you ever done surgery on a thumb? So I did do a hand fellowship and have done a lot of surgery on the thumb for typical hand orthopedic musculoskeletal reasons. I've also done surgery in the thumb area for peripheral nerve problems. There's nerves that go into the thumb that can be cut or damaged or injured. And so the short answer is yes. If this is a peripheral nerve problem that the patient is having, I still do surgery in the hand and the thumb, but I don't do surgery for typical, musculoskeletal reasons, bone fractures, joint arthritis, tendon injuries, those type of things. I let my hand colleagues who are much more experienced at that than I am handle those kind of problems. Next question, submitted by someone named Petra, and this person's question says, "I feel heaviness in my foot, like I have a weight on it, and pain in my right leg. This pain is sometimes posterior. I'm guessing meaning the back of the leg, back of the thigh, and also in front of the thigh and calf. I feel this pain mostly when I start to walk or push my leg when riding a bike or just walking. My gait is different. It looks like my leg is heavy and tired, and my buttock burns. All of this is on my right side. Is this Piriformis Syndrome?" So certainly everything that this patient is describing could be consistent with Piriformis Syndrome. And Piriformis Syndrome is simply compression of the sciatic nerve in the deep gluteal space, sort of the deep central buttock area, where the nerve gets compressed between the bony pelvis and the piriformis muscle, which runs over the top of the nerve. So in anatomical terms, it gets compressed between the bone of the pelvis anteriorly and the piriformis muscle posteriorly. It would be kind of a mistake, though, to just assume that this is Piriformis Syndrome, because there are some other things that could also cause these kind of symptoms. The most likely one would be that this person is experiencing some kind of compression at the spine level. This is probably not a spinal stenosis situation where the spinal cord itself is being compressed, because that typically presents as bilateral symptoms or symptoms in both legs, sort of from the waist down. So since this is only these symptoms are only affecting the right side, the right leg and foot, etc., this person needs to have an MRI of the lumbar spine at a minimum to make sure that there's not a nerve root or multiple nerve roots that are compressed on the right side, because that could also cause these kind of symptoms. And then something that could cause symptoms similar to this, but would be much less common, is if this patient has a problem with the arterial blood flow into the right leg. For example, if they had like an aneurysm in the pelvis involving the main blood supply to the right leg, that could also cause some type of vascular claudication symptoms. This person, their symptoms get worse when they're active, riding the bike or walking. Without some more detail, it'd be hard to know if this really sounds like a vascular claudication situation. But if that would be something that could be evaluated by a vascular surgeon. They may want to do imaging, like a CT angiogram of those blood vessels in the pelvis and lower leg. And there's other ways to evaluate that. But certainly everything that this patient describes could be consistent with Piriformis Syndrome as well. Next question, submitted by Leslie. It says, "For diagnosing Piriformis Syndrome, do I get an MRI or an MRN?" And an MRN stands for magnetic resonance neurography. So it's a type of MRI that just is more specialized to look at the nerve tissue in the pelvis and lumbar area. She goes on, "If the piriformis looks normal on MRN imaging, but a piriformis diagnostic injection provides great relief, does that mean the imaging was not accurate? Or does that mean the numbing medication bathed other areas close to the piriformis that are the problem?" So this is a very astute question. I commend Leslie for being so savvy about this kind of thing. But what I would say is that there's no imaging, including MR neurography, which is the best nerve imaging we currently possess. that is foolproof. So an MRN that is normal does not rule out piriformis syndrome. It's only useful if it clearly identifies markers that are consistent with piriformis syndrome, like the piriformis muscle on the symptomatic side being, enlarged or even atrophied, or sort of the smoking gun is if the imaging study shows inflammation of the sciatic nerve through the area of the greater sciatic notch and where it passes underneath the piriformis muscle. That's sort of the best evidence you can get from MR neurography. But an MR neurography that is totally normal certainly does not rule out the condition. So if a patient has a normal MRN and then gets a diagnostic injection into the piriformis muscle that relieves the problem, the most likely thing that indicates is that she does have true piriformis syndrome. Now, her question about numbing medication bathing other areas close to the piriformis syndrome and potentially producing a false positive result, meaning she gets the injection, her sciatica symptoms go away, and so you just assume, yeah, it's piriformis syndrome. What you have to do is really pay attention to what the patient experiences after the piriformis injection. A perfectly done piriformis injection should inject the local anesthetic into the piriformis muscle, and that should be contained by the fascia surrounding the piriformis muscle, and it shouldn't bleed out onto anything else. So therefore, the patient who has a perfectly accurate piriformis diagnostic injection performed should not experience any numbness anywhere. They should not experience any numbness involving, except for maybe a little bit of the skin where the needle goes in, because they'll typically numb that up because they have to use a longer, deeper needle to get to the piriformis muscle. But other than the little patch of skin around where they insert the larger needle for the injection, they shouldn't be experiencing any numbness between the legs or any significant numbness of the skin over the buttock or any numbness in the leg at all. One thing that can happen frequently is that the needle may, pierce through, or it may not be actually in the piriformis muscle, and then the most likely thing that's going to happen is the sciatic nerve itself is going to get numbed up. The second most likely thing is that the posterior femoral cutaneous nerve could also become numb. And so in those situations, if it's just the posterior femoral cutaneous nerve that becomes numb, then the patient should experience numbness involving the skin over the lower buttock and the back of the thigh, maybe down into the upper posterior calf area. If the sciatic nerve is involved and becomes affected by the anesthetic, then the patient could experience weakness in the leg and also numbness below the knee level. So the lower leg and the foot typically will feel numb to the patient. And in that case, I always recommend repeating the block, because if you get the medicine on the posterior femoral cutaneous nerve or the sciatic nerve, it really degrades the diagnostic usefulness of that procedure. But in this situation, I would say that a normal MRN and then a piriformis injection that doesn't make anything else go numb but relieves the sciatica pain is a very good indication that the true problem is piriformis syndrome. Next question, submitted by someone named Bill. And Bill states, "Good afternoon. I have had piriformis syndrome for about 13 years on both sides. The symptoms are different from one side to the other. The left side is the worst. When I drive and press the gas pedal, I get nerve pain down the back of my leg." I think Bill meant to say right side in this next sentence, but he says left side again, but I'm assuming it's right side. He says, so I'm going to just insert right side. It says, "The right side is very different. There is sciatic type nerve pain, but most of my pain appears to be a very mad obturator internus muscle. I cannot get the muscle to calm down. With the left side, I get nerve pain in my feet. Over the years, my feet are starting to cramp a lot. I cannot get the piriformis muscle to free up. Have you seen this before? Thanks for your time." So Bill is describing sort of sciatica pain on both sides that's different qualitatively from the left side to the right side. It sounds like on the right side, his pain is more isolated to the buttock area and does not travel down the right leg. And on the left side, he has sort of the more classic sciatica pain with symptoms that go all the way down into his foot. So again, the place to start with these kind of symptoms is to make sure that the lumbar spine is not the cause of one or both sides in terms of the symptoms he's experiencing. So an MRI of the lumbar spine, if that looks pretty normal, then ideally an MRN of the pelvis is also useful. It is absolutely possible to have piriformis syndrome on both sides, but to have different clinical symptoms in the way they present. I would say that very often, especially if his left side is the real severe side. So I see patients very frequently who'll have, they feel like they have bilateral piriformis syndrome and they have symptoms on both sides. And what you'll see is that one side is very severe and they have pain that goes from the buttock and all the way down into the foot. And then the other side, they'll have buttock pain, but maybe no radiation down into the leg. And maybe their symptoms are like 70% on the severe side and 30% on the not so severe side. So that's pretty common. That can be one of two things. It can mean that on the less severe side, what they're experiencing is not due to true piriformis syndrome, but a referral of pain where the brain kind of gets confused about which side is the problem. And so when you get severe pain on the affected side, there can be this bleed over effect, and the patient can also experience symptoms on the opposite side. It can also be the case that they do have actual piriformis syndrome, but it's just more severe on one side, and so the symptoms are much more involved and extensive on the more severe side, and not as bad on the less severe side. I would also say with that, he specifically says it appears to be a very mad obturator internus muscle. I would take a little bit of, I would be cautious about that. Most likely, he's been told that this pain on his right side is due to an obturator internus muscle, probably by a physical therapist or somebody of that nature. Typically, muscles themselves, if this was an obturator internus muscle problem, that is something that should show up pretty clearly on an MRI, meaning there should be some evidence of a tear to the muscle or some kind of injury to the muscle. But most often what happens in these situations is, people see all these physical therapists and other doctors and stuff who don't know much about peripheral nerves, and they get told all kinds of things. And so most likely this is not a problem with the obturator internus muscle, but some other peripheral nerve issue that just hasn't been identified correctly. Possibly piriformis syndrome, possibly something else. Next question was submitted anonymously, and it says, is it possible for neurectomy of the lateral femoral cutaneous nerve for Meralgia Paresthetica to be unsuccessful? If so, how and what would be the solution? Can a patient who has had a neurectomy ever be stuck with phantom pain forever? So we've kind of touched on this in some of the previous questions. Obviously, yes, you can have unsuccessful surgery if the surgeon who cuts your nerve doesn't really know how to treat the upstream end of the nerve. Every peripheral nerve is like an electrical wire. The battery is your spinal cord, and then the wire goes to the big toe, for example. Or in the case of the lateral femoral cutaneous nerve, it goes to innervate the skin over the front and outside part of the thigh. Now, when you cut a peripheral nerve, it's like clipping an electrical wire. The downstream end is a dead, inert piece of copper, and the upstream end still has electricity in it because it's attached to the power source. Same with the peripheral nerve. When you cut the peripheral nerve, the downstream end becomes sort of an inert structure, and the axon itself will actually be resorbed by the body. The upstream end, however, in peripheral nerves, is still alive. It's still electrified, and it wants to grow and find that downstream end and regrow and reinnervate whatever it was supposed to innervate originally. And so that's why it's so important when you're disconnecting nerves to get rid of pain that you know how to appropriately treat the proximal or upstream end of the nerve. And so, one possibility for a neurectomy of the lateral femoral cutaneous nerve to fail would be that it wasn't cut at the right level or treated appropriately, and so now the patient is dealing with a painful neuroma. The other possibility is that there's nerve anatomy that wasn't recognized, complex nerve anatomy that was not recognized by the surgeon, and so he may have taken out one nerve and left other nerves present that are still causing pain. The other part of his he asked what would the solution to that be. Obviously, it would be to have somebody who has the experience to identify these things and go in and fix the problem, and it should be able to be fixed. And then he asks if phantom pain can last forever. Again, in my experience, if the correct nerves have been identified and dealt with appropriately, there's nobody that I've ever seen that phantom pain lasts forever. When phantom pain or quote unquote phantom pain is still ongoing, you're dealing with a problem that hasn't been recognized or addressed inappropriately. You have to go back and figure that out. Next question submitted by someone named Paolo, and he says, "Hello, I have back and rib pain from a trauma for 9 years. I feel burning pain in the back and ribs, somewhere in the 7, 8, and 9 intercostal area on the left side. I did 3 times intercostal blocks, but without so much relief from the pain. The pain is every day. Can you tell me if you deal with such problems? Thank you." So the answer to the last part is absolutely. I deal with these kind of problems on a frequent basis, and these kind of problems that involve intercostal nerves in the torso area can be quite complex to figure out and deal with, because the anatomy, first of all, with every rib, there's a nerve that runs just on the inferior margin of that rib. The ribs don't come out at exactly a 90-degree angle and then just wrap around, at a 90-degree angle to the front. They kind of come out and travel at a little bit of an oblique angle. And then you have branches that are coming off all these ribs that travel sort of in a different plane and at a different angle than the ribs do. So blunt trauma to a certain area that may fracture 2 or 3 ribs can damage those specific intercostal nerves, but they can also damage some of the branches from a nerve above, typically above, but possibly also below those nerves. The other issue with intercostal nerves is that for any given nerve, there's usually connections that are branching off the nerve above it and the nerve below it and coming in and connecting to that nerve. So if you injure the 8th intercostal nerve, you may have to take out 7, 8, and 9 to get good relief from the pain, because depending on where you cut the nerve, you may have another electrical source coming in from the nerve above or the nerve below downstream from where you cut the nerve, and that sort of frustrates the purpose of the operation. So you have to be aware of these kind of things when you're dealing with intercostal nerve pain. But this is the type of problem that should absolutely be able to be fixed by somebody who knows what they're doing. Next question submitted by Patty. And Patty says, "Hello, Dr. Tollestrup. My name is Patty, and I'm 68 years old and had knee replacement surgery 3 weeks ago. I have had sciatica for quite a while, and I was getting injections in my back, which did help. Since my knee surgery, I am getting terrible pain on the lateral side of the knee, which sometimes hurts down the side of the calf. I saw my surgeon yesterday, and he said it is probably hamstring pain and gave me a steroid injection in the knee. I also have buttock pain, which travels down the side of my leg. The pain is always worse at night and sometimes unbearable. I should add that I have also taken 2 rounds of Medrol. I am being referred now to a spine surgeon. Do my symptoms sound like piriformis pain? Thank you so much, Patty." So this is an interesting case. So it sounds like, if I'm understanding what she is writing correctly, that she had sciatica pain which predates the knee replacement surgery. So that's sort of a more chronic ongoing thing. And then 3 weeks ago, she had this knee replacement surgery, and now she's dealing with a new pain. In addition to the sciatica pain, she's dealing with a new pain on the outside area of the knee, which can radiate down into the sort of outside part of the lower leg. So let me take this from the top down. So in terms of the chronic sciatica pain that predated the knee surgery, but is also now, kind of worse since the surgery, again, you just have to approach all these problems sort of methodically. So she should have an MRI of the lumbar spine, make sure that there's not an obvious compression of one of the nerve roots there that's causing that sciatica pain. Now, assuming that she gets the MRI of the lumbar spine and that doesn't show a problem, that it's negative, that there's no explanation at the spine level for why she should be having these symptoms, then the very next most likely source of that type of sciatic pain would be a piriformis syndrome. Now, when you have a total knee replacement, for those of you who haven't had the opportunity to watch one of these surgeries, it's kind of a brutal surgery, as a lot of orthopedic joint surgery is. They cut out the knee joint, the diseased arthritic knee joint, and they put in a new knee joint. That can involve some tugging, and especially once the knee joint has been removed, if they have any difficulty or put too much stretch on the lower leg to try and get that new knee joint in, or just simply the trauma, the swelling, the inflammation around the knee area that goes along with any type of a total knee arthroplasty, that certainly can compromise the big nerves that are running through that area to go down to the lower leg and the foot. The nerve that's most at risk from a total knee replacement surgery would be the common peroneal nerve. There's a natural compression point for that nerve that occurs just on the outside of the knee, sort of slightly below the knee joint, where the nerve passes over the fibular neck. So the fibula is that second smaller bone that goes between the knee and the ankle. It's to the outside, so your outside ankle bone is the bottom part of that fibula. And then the fibular head, which is near the outside of the knee, is less obvious, but that's the fibula bone. The common peroneal nerve comes from behind or in the back of the thigh and sort of the back of the knee, and it comes and curls around that fibular neck bone. And then running in the front of the nerve there, it can be a tough fascial or even tendinous type of band, which is part of the peroneus longus muscle. So where that nerve leaves the back of the knee and enters into the lateral compartment of the lower leg is a natural compression point. With any kind of swelling due to a knee replacement surgery, that nerve can easily become compressed or pinched. Also, if this patient has a history of chronic sciatica, if this is due either to a nerve compression at the spine level or a piriformis syndrome, what that does is it predisposes the nerve tissue downstream from that compression point to develop secondary nerve compression. It could be that this lady already had some component of a nerve compression that was subclinical, or it could be that tension or pulling on the leg during surgery injured the nerve slightly and led to a nerve compression. So this kind of a situation where somebody undergoes a knee replacement and then has pain referable to that outside of the knee, radiating into that sort of lower outside part of the leg, is very consistent with a potential common peroneal nerve compression. In addition, she may also have piriformis syndrome or something happening at the spine level, and you just need somebody who understands these problems to work through that and figure out where the issues lay. Next question submitted by a person named Eileen, and Eileen states, have you treated women for intravaginal nerve pain? This is ongoing for 24 years. I am 82 now. As I get older, the pain is worsening. So the answer to that question is yes, I do treat women for intravaginal pain. There's a specific nerve that innervates all that area between the legs in both men and women, the genitalia and the anal rectal area, and this nerve is called the pudendal nerve. Women are much more likely to develop problems with this nerve just by virtue of things like childbirth and any kind of surgery that has to be done, whether it's a transvaginal hysterectomy or anything like that. Specifically, the distal third of the vagina is innervated by branches that come off the pudendal nerve called the peroneal branches. And these nerves, any kind of trauma to the vaginal area, an episiotomy, tearing during childbirth, blunt trauma to the perineal area, which can affect both men and women, can really compromise these peroneal nerves. And so very likely the pain that this patient or this person is experiencing is related to problems with the peroneal branches of the pudendal nerve. Now, when somebody comes in and gives you this kind of history, you have to ask them other questions like, do they have buttock pain or anorectal pain? Is there clinical or clitoral involvement, labial involvement, or is it just simply vaginal pain? Because that gives you an idea of, is it just these branches that are coming off to the vaginal area that have been injured, or is there potentially a posterior compression of the pudendal nerve, which should then cause more widespread symptoms? Sometimes when patients have peripheral nerve problems in a nerve tree where one branch is the primary problem, they sort of discount or neglect to talk about symptoms in other areas. But it's important as the clinician to ask these questions so you can get a clear picture. But this is the type of problem that should absolutely be able to be fixed. It would start with a diagnostic block of the pudendal nerve and see if that makes the vaginal pain go away. And then you know for sure that it's these nerves that are a problem, and you can go in and treat them appropriately. And in this case, if it's the perineal branches, the treatment would be to disconnect those little branches, and that should resolve the pain. Next question is submitted by a patient named Anna. And Anna asks, she says, for neurogenic thoracic outlet syndrome, where is the incision made? How large is it? And do you also treat other entrapments at the same time? For example, the dorsal scapular and subscapular nerves. Also, is neurogenic thoracic outlet syndrome surgery successful even if you have had the condition for 3 years? So this is a type of peripheral nerve problem that often goes undiagnosed or incorrectly diagnosed. Thoracic outlet syndrome can be due. There's 3 types of it, I should say. One is neurogenic, involving nerves. One is arterial, involving the arteries that take blood down into the arm. And one is venous, involving the veins, which allow blood to come back out of the arm and back to the heart. Of those 3 types, neurogenic is by far and away the most common, making up approximately 95% of cases. The arterial thoracic outlet syndrome and venous thoracic outlet syndrome together comprise the other 5%. The irony of this is that it's usually pretty straightforward to diagnose either the venous or arterial forms of thoracic outlet syndrome because there's obvious physical manifestations. In the case of venous thoracic outlet syndrome, the arm will often be swollen and be dusky, bluish color because the venous blood is unable to get back out of the arm. In the arterial form, the arm may be kind of pale white, there won't be any pulses, etc. And then typically imaging can often show either an aneurysm in the arterial form or clotting of the venous system in the venous form or what have you. And so that can be diagnosed pretty quickly and taken care of by a good vascular surgeon. Neurogenic thoracic outlet syndrome, on the other hand, can present wildly differently from one person to another because there's so many nerves involved. The condition is actually compression of the brachial plexus between the anterior and middle scalene. There can be other compression points, but they're much less common. Most neurogenic thoracic outlet syndrome, the primary issue is going to be compression of the brachial plexus between these 2 small muscles in the side of the neck. And so the nerves that are involved typically are the nerve roots C5, C6, C7, C8, and the first thoracic one, T1. And as those nerves come out of the side of the spine, they sort of, they'll go together, split apart, and create this sort of web, which is called a plexus. And that's happening really from the level of the spine all the way to about the shoulder joint, after which point the nerves form specific named nerves that then, travel down the arm. But so people with thoracic outlet syndrome, the correct treatment for that is to remove the anterior and the middle scalene muscle, and that's done through a relatively small incision at the base of the neck. The way I do mine is I make sort of an L-type incision. You can see here, I can't really do this as I'm doing it backwards, but the incision starts here. It would go like this and then up the neck like that. So it's a relatively small incision, and then it just depends on your surgeon how well they do skin closure as to what the scar is going to look like. But you're going to have a little L-shaped scar there after the fact. And then when you're in there, you're really doing everything because you don't ever want to go back. So you're taking out the anterior scalene muscle completely, or you should be. You're taking out the middle scalene muscle completely, or you should be. And then you're decompressing the C5, C6, C7, C8, and T1 nerve roots. You're decompressing the upper, middle, and lower trunk of the plexus, and then the nerves distal to that. You want to make sure that there's no scalenus minimus muscle that's individually or specifically compressing the lower C8 and T1 nerve roots. As part of taking out the middle scalene muscle, you're decompressing the dorsal scapular nerve and the long thoracic nerves. The suprascapular nerve, the subscapular nerve also it can be an issue, but it's not typically a part of brachial plexus problems. So that's not usually an issue. You can get a compression of that nerve where it passes through the scapular notch, but that's a much more rare condition. Usually when that happens, you can identify it using an EMG, and you don't have the widespread symptoms that go along with thoracic outlet. So the odds of having both a compression of the brachial plexus and an issue with the scapular nerve is not real high, but certainly something you can think about. The way to treat it would be with any nerve issue, the way to treat it is when you might have multiple nerves compressed at different levels is to start upstream. So the next possible place other than the spine where the nerves can be compressed, and address that nerve compression first, and then see if there's actually symptoms left over and whether or not you need to do more distal compressions. That's generally the rule. And so that prevents you from doing unnecessary surgery. Next question submitted by someone named Roro. And this person says, I saw a neurosurgeon who said I have compression on my lumbar 3 and 4 nerve roots and central stenosis, meaning the space for the spinal cord is also narrowed. He recommended a pain specialist. The pain doctor looked at the MRI and x-rays and said he wanted to try epidural injections. So I'm having an epidural in my lumbar spine tomorrow, hoping it relieves my back, legs, and feet pain and discomfort. My question is, can this help heal my discomfort mostly in my knees and feet? So the question here is, what exactly is the problem? If your MRI imaging of the lumbar spine really shows significant central canal stenosis or compression of one of the nerve roots, the L3 and L4, for example, then probably the purpose of this epidural injection, if it's kind of like a questionable call, the epidural can be a good diagnostic intervention. If it relieves a lot of your pain or relieves all of your pain, then you know that the problem is at the spine level. Sometimes 1 or 2 epidurals can really improve the situation and prevent the need for spine surgery. But it's unlikely that it's going to be a permanent long-term fix because there is, tissue that's compressing the spinal cord, the nerve roots, what have you. And so over time, those types of problems tend to get worse, not better. If, on the other hand, another common scenario that happens, for example, in this type of situation is that the patient presents with, back pain, sciatica pain, what have you. If they're if they're 50, 60, older, there's going to be all kinds of degenerative changes on the lumbar spine. And then you get in a situation where the spine surgeon looks at them and, listens to what the patient's saying and is sort of like, well, it's not, obvious, but I think that this is probably the source of the problem, and that's where you can easily get into a situation where the patient undergoes unnecessary spine surgery. So if the epidural doesn't really do anything for you, then you really have to stop and question whether or not the problem is coming from your back. In that case, I would definitely consider a second opinion, get another spine surgeon to look at the imaging and see what they think and review the results of the epidural. And then, if the epidural doesn't do anything for you, it would also be valuable to see somebody who knows how to do a good peripheral nerve evaluation, because maybe you're dealing with a peripheral nerve problem and not a problem coming from the spine. But the main question there is, can an epidural heal this discomfort? I would say that heal is probably the wrong word, unless for some reason this is just due to acute inflammation. In that case, an epidural can be very effective and resolve the problem permanently. But if this is a case where you do have some form of compression on the nerves, if the epidural works, it's probably going to be temporary, although it could give you months of relief, but then the symptoms are likely to come back. Okay, next question from Leanne. She asks, would RFA, or radio frequency ablation, on the middle cluneal nerves jeopardize or complicate middle cluneal nerve removal surgery? The answer is it could, to some degree, but it's not a major issue. Meaning, if you had RFA, it doesn't mean that you can't have, MCN removal surgery down the road. What RFA is it involves sticking a needle somewhere and then burning the tissue at the end of the needle to try and kill nerve tissue, and it's like cutting a nerve, but not permanently, because they don't actually change the architecture of the nerve by removing a piece. They just kill the axon inside. And as we talked about before, nerves are kind of like copper wires with a rubber insulation coating. So what RFA does is it kills the copper wire, but leaves the rubber insulation intact. And so as soon as you get to the periphery of that burn, you're going to have on the upstream end, right, the end that's attached to the power source, which is the spinal cord, you're going to have a live peripheral nerve who wants to regrow down that tube to the end. And that's exactly what it will do. And that's why RFA is typically a temporary solution, although it can be, it can give 6 months or even a year relief before that nerve can grow back and reinnervate whatever it was innervating originally and have recurrence of pain. So my understanding, and again, I'm not the type of doctor who does these RFA procedures, but most people would not be a candidate for RFA, for an RFA procedure for middle cluneal nerves, because those nerves are pretty close to the skin surface, or there's not a lot of tissue between the skin and where these nerves are coming out of the sacrum. And so a lot of pain management doctors, or the ones that I've talked to, often will decline to do that procedure because there's too much of a risk of burning the skin and causing a lot of necrosis of the skin at the same time. RFA works better when the nerve that they're targeting is deeper. But again, that may change depending on the patient, how big or small the patient is, and the comfort level of the person doing the procedure. But in general, RFA of any nerve does not prohibit downstream or down the road nerve surgery to cut those nerves. It can make it a little more difficult, but not that much usually. Next question is a fairly extensive question. This was submitted by someone named Jonah or Joan. And the question is, this person says, hi, I've had Meralgia Paresthetica for 3 years now. It was confirmed by ultrasound, which shows my lateral femoral cutaneous nerve compressed under the inguinal ligament and thickened distally. So this is a pretty good indication that the lateral femoral cutaneous nerve is a problem, because they can actually see the swelling where the nerve passes underneath the tough inguinal ligament. I've also had successful nerve blocks. So in this case, this diagnosis is pretty much 100% sure. Last spring, I had an open inguinal hernia repair with mesh on the same side as my Meralgia Paresthetica problem. I had some complications from the surgery, including a hematoma. So what happens is there was some bleeding into the incision and creates a mass, a ball of blood in there, and that's called a hematoma. Since my surgery, my Meralgia Paresthetica has greatly worsened. In addition to the thigh burning pain, which happens mostly when sitting, I also have an awful pressure sensation around the anterior superior iliac spine. That's sort of your front hip bone, and that nerve typically, the lateral femoral cutaneous nerve, typically exits the pelvic just to the inside of that bone. So right in that area, this person is getting an awful pressure sensation, especially when the waistband of clothes hit this area, which is most of the time. I am constantly unbuttoning my pants or pulling down my waistband to relieve this pressure I feel. So that's what's going on. Then the question is, I am going to have a surgery to disconnect, i.e. a neurectomy, my lateral femoral cutaneous nerve. I am concerned with how much of the inguinal ligament must be cut or manipulated since my hernia mesh is sutured to the inguinal ligament. I know the lateral femoral cutaneous nerve neurectomy occurs higher up on the inguinal ligament, but how concerned should I be that the neurectomy surgery could interfere with or compromise my previous hernia mesh surgery? Is there something the surgeon can do to ensure my hernia repair isn't weakened or compromised? How important is the surgeon's skill and familiarity with this nerve regarding people who have had inguinal hernia repair? Does lateral femoral cutaneous nerve neurectomy surgery have to go through the inguinal ligament or cut through it, or can it be avoided, or is it avoided anyways? My surgeon is a peripheral nerve surgeon from Columbia Presbyterian in New York City. He says that he has done quite a few decompressions and neurectomies of the lateral femoral cutaneous nerve, but wouldn't give me a number. When I asked about this surgery and my hernia repair, he said he didn't think there would be any issues compromising my hernia repair. I'm wondering if my case should be handled by someone more experienced like you or Dr. Williams, referring to Eric Williams out in Baltimore, or if this should be a routine enough and straightforward operation for my surgeon to handle. Okay, so there's a lot to unpack here in this question. No question that this patient has Meralgia Paresthetica in my impression just from the description. So anytime, just as a general rule, anytime there's another surgical procedure that's done in the vicinity of a nerve that's compressed, there's a very high likelihood that that nerve compression is going to be made worse, and therefore the patient's symptoms are going to be made worse. When you do a hernia repair surgery, an inguinal hernia repair, you're dissecting very close to the lateral femoral cutaneous nerve where it exits the pelvis. There's going to be, even if the surgery goes perfectly, there's a very robust inflammatory reaction, swelling that goes on with that foreign body, the mesh that's put in there. And that's going to tend to make a tight space around a nerve contract and shrink and become even tighter. You add into that a hematoma. Blood in tissue like that is very irritating to the body tissue and causes a robust inflammatory reaction as well, and a lot more scarring. So that also can contribute to the worsening of the Meralgia Paresthetica issue. So now this person is seeing a peripheral nerve surgeon in New York City. I know that there's no one in New York City that has had the type of training that I've had or that Dr. Williams in Baltimore has had. Most of the time, when you find someone who calls themselves a peripheral nerve surgeon, what they really are is a reconstructive peripheral nerve surgeon. And reconstructive peripheral nerve surgery is much different than pain-focused peripheral nerve surgery, which is what I focus on. And so my guess is that, well, this doctor probably has done, surgery on the lateral femoral cutaneous nerve before. It's likely that they haven't done very many of them, and that we're talking about maybe a handful of these procedures that they do in a year, maybe even less. That's why he's reluctant to give numbers. That being the case, if they are a good surgeon and they've done this procedure before and know how to do it correctly, there's not necessarily a specific reason why they can't do this one as well. But I would just say that all things being equal, especially with surgery on this nerve, given the quite variable nature of the anatomy, that you want to go somebody who's more experienced rather than less experienced. So this person sounds like they're from the East Coast, as they're already scheduled to go to see somebody in New York City. So Dr. Williams in Baltimore would be an excellent option to at least get a second opinion from before doing that. Now, having said that, is if they do have this surgery and it doesn't work out well, then I can fix it. So do with that information what you will, but I would just generally encourage everyone who has any kind of a peripheral nerve problem that's a pain issue to really search out a surgeon that's been trained to deal with those kind of problems, and not the type of surgeon that generally reconnects nerve and fixes damaged nerves, because that's a completely different field of surgery. And most of the time, those surgeons are operating on nerves in the upper extremity, the hand and forearm. And it's unusual that you get somebody who's done a high volume of surgery on the lateral femoral cutaneous nerve. Last question that we have for right now is a question that was submitted by someone named Cindy. And Cindy says, I've had middle cluneal nerve diagnostic injections and piriformis diagnostic injections. After each one, I had pain that I had never had. There's a little bit odd wording, but it says I had pain that I never had before that innervates the path where the nerves are located. It has been 9 months and the pain has not returned to base pain. Do you think that this is an indication that those are the nerves that are causing my pain, or do you think that the nerves are damaged from the injection? With this amount of information, it's a little bit hard to know exactly what's going on, but generally speaking, anytime you are going to perform a diagnostic block on any nerve or try and inject the piriformis muscle for Piriformis Syndrome, there is a small risk that you could irritate those nerves and cause new symptoms where you didn't have symptoms before. That's why it's really critical to go to somebody who kind of knows how to work these problems up, so you're not getting blocks on nerves that may not be necessary. And then the other issue is that you really want to have somebody who's doing the blocks be someone who's got a lot of experience doing these blocks. You don't want to go to somebody and have them inject your piriformis muscle if they've done 2 of these before in their career, or do like 1 or 2 a year. You want to go to somebody who's done it a lot, and that minimizes the risk of injuring nerves or causing problems where there weren't problems before. So generally speaking, if you have a diagnostic block, if you've targeted the correct nerves and the block is accurate, you should have either complete cessation of the pain or dramatic reduction of the pain for some period of time, usually measured in hours because the local anesthetic doesn't last forever. If you get a diagnostic block and it causes some kind of new pain which persists for days, weeks, or months, then you're probably dealing with an injury to peripheral nerves. And that doesn't mean that the problem that's where your original pain came from. It means more likely that you've had an injury to nerves as a result of the procedure to block those nerves. Now let's see. That pretty much takes care of all the questions that we had submitted.